Thank you very much, Professor Chen, and thanks to the organizers for having me on board. I've been very impressed by the first two talks, and I've taken copious notes as to how we might do things a bit better in Australia as well. So I was asked to talk about antifungal stewardship, and we've heard a lot about antimicrobial stewardship, but this one will be focusing more on fungi rather than bacteria. These are my disclosures, which haven't changed from yesterday. So what I thought I'd do today is to go through why antifungal stewardship is important. And we know it's important because we want to slow down antimicrobial resistance or antifungal resistance. But which fungi do we worry about? So a little more about that. What actually is AMS in terms of fungal medical mycology? What strategies can we learn from bacteria? Because the bacteriologists do this very well, and also from viruses. Who is meant to be doing AMS, and what is the evidence supporting it? So that's kind of the plan for this talk. Just borrowing a slide from the WHO, we know that AMR is a global problem. WHO declared AMR as one of the top 10 global health threats, which results in about 700,000 deaths a year globally, more than deaths due to multi-drug resistant TB. Many newborns die a year, particularly in India, from AMR, and it's a condition which results in disability of many, many, many years. And you can read all about it in the WHO publications on their website. So AMR is also a national problem for us, and you might be interested to know that Australia's top 3 resistant threats are bacteria. So CRE, that the first speaker spoke up to, and up to half of bloodstream infections caused by CRE result in death. Then we have MRSA and VRE. And stewardship for bacteria is well developed in Australia, thanks very much to the efforts of Professor John Turnage, Dr. Jan Bell, and Professor Karen Thursky, even a little bit in the antifungal space. Our National Surveillance Program, otherwise known as AURA, in its latest 2019 report, had detailed 200-page document on bacteria, but there was no mention of fungi. But this is about to change for 2023, so watch this space. What causes antifungal resistance? This is slightly hypothetical, but I think it's useful to have a framework. So we have fungi. They can turn on their genes responsible for resistance if they're edged to do so. They can change to protect themselves. We know that this can happen with bacteria, but the molecular clock in fungi is very much slower. And thankfully, we haven't seen a lot of evidence about fungi changing to protect themselves. They may receive resistant genes from other fungi. Again, in bacteria, this is very well developed. There are thankfully no plasmids that can transmit antifungal resistance between fungi. So what are the other factors? There's agriculture and the environment. So we use antifungals in the environment and we use it with abundance. Poor hand hygiene perhaps may contribute to antifungal resistance. Antifungal use, certainly very, very important as a factor in determining whether fungi are becoming resistant. Poor infection control and infection prevention, like hand hygiene, and finally travel. But the big two are antifungal use and agricultural and environmental use of antifungals. And I think this is the money where we turn our attention to, not to say that the other factors aren't important. Everything is important. So the main players that we worry about, Candida species, so Glabratus, Auris, Tropicalis, and others. Aspergillus fumigatus complex, in particular Aspergillus fumigatus sensu stricto, and increasingly some rare molds, and increasingly non-Candida uncommon yeasts, like Rhodotorula, like Saprochaetes. They're all coming to play, particularly in immunocompromised patients. I thought this slide might be useful to summarize inherited and acquired resistance in yeast, particularly when you're designing surveillance programs like you have. And the left-hand side just shows the genus or species of the fungus concerned. The middle column shows the inherent resistance. So for like glabratus, we know they're inherently resistant to triazoles. And C. krusei, I'm being a bit naughty by using its old name, but let's stick with krusei for now. Also inherently resistant triazoles, but they can also have acquired resistance, and they can all require resistance to echinocandins. You note that for the non-candida yeast, the inherent resistances include the echinocandins, and this is often our first-line treatment for candida infections. Excuse me. And therefore, it makes sense that the lab that you're using for diagnosis knows how to carefully and accurately ID candida organisms from non-candida organisms. So you can see echinocandins, they're not active against trichosporins, Saccharomyces, Sapochetes. They do have some activity against Rhodotorula, but in this genus, triazoles have inherent resistance. Moving on to the moles, so here we have a number of Aspergillus species, the Mucorales, Fusarium, and Lamentaspora. Inherent resistance is characteristic of all these genera, and it varies according to which genus or species you're dealing with. Of note, Lamentaspora prolificans is pan-resistant, pan-drug resistant, very difficult to treat. We know that Aspergillus fumigatus can acquire resistance to the first-line treatments as well, and these include Vori and more latterly isavuconazole. Terrius is also resistant to amphotericin. We don't really know about acquired resistance in these rare moles, and that's because they haven't been adequately studied, but I understand that a lot of research attention is now being addressed in that direction. So, once we now decide what to worry about, let's have a stewardship program. And AMS, as the first two speakers have carefully and very detailed in delineated, is just simply a systematic approach to optimizing use of antifungals, with the aims of firstly reducing inappropriate antifungal use. That makes sense. In turn, this will lead to improved patient outcomes, reduce adverse effects or toxicity, reduce development of antimicrobial resistance, and reduce costs. And hospital administrators are always very happy to see this in any brief that they might receive. What are some of the essential strategies? First, you must have your team. And who do we have on the team? We'll go into that. Secondly, we must have a policy, a restricted antimicrobial formulary. Education is paramount and critical, not just to the hospital, but to other healthcare providers. Implement some clinical guidelines, be consistent with whatever your local bodies have published or want you to do with the therapeutic guidelines if you have them in your country. The fifth condition is really very important, is that we need to review our antimicrobial, antifungal prescribing with the intervention, and then re-review that, monitor antifungal use, and monitor outcomes. This is one structure of a team, and let's start from the bottom. I know this is slightly small. Here we have frontline healthcare workers. This is us, doctors, nurses, scientists, nursing champions, and external sites. And then we have middle layer management, the Antimicrobial Stewardship Committee that ID physicians, and medical people and nurses and pharmacists should have input into. And this works alongside bodies like the Drug Committee, the Medication Safety Committee, the Patient Safety and Quality Committee. On top, we have clinical governance. And this is paramount because if you don't have buy-in from clinical governance, it's not going to work, even if the hospital CE agrees. So I'm not negating the role of the hospital executive, but it's really your clinical governance that controls how effective an antimicrobial stewardship committee is. So have a care as to where the governance sits. What about the policy and the formulary restrictions? Well, we all have a list of medications that are available for us to prescribe. This is determined by the Hospital Drug and the Therapeutics Committee. We have restrictions, and it's good to have, a page or document which outlines this, and this may include restrictions by prescriber. So whether you are restricted to the ID physicians or to the ICU physicians or hematologists, you may restrict it by indication, e.g. pip/tazo for neutropenia, but it all should be determined by the AMS committee. And many hospitals in Australia now have used a traffic light system, which one example is shown here. So green, amber, and red. So green is unrestricted, can be prescribed without approval. Examples include benpen, doxycycline. Restricted or protected, so it does require approval within a nominated time of medicine, but you're given a sort of 24 to 48 hours before the pharmacist comes down on you. And examples are broad spectrum antimicrobials. Then we have the highly restricted group, which requires discussion with a nominated expert to obtain approval. Often, a full formal specialist clinical consultation for these patients is also recommended. Not mandated, but just recommended. And examples of these highly restricted drugs include antimicrobials viewed as last-line agents and reserved for highly resistant pathogens, or medicines with high potential toxicity or high cost, such as echinocandins, liposomal amphotericin, which is missing from this list, and a number of antibacterials. So we can see the antifungals coming into the creep here. What about our systems? There are a few approaches already that are tailored to hospitals, if one does work in a hospital, and there are electronic approval systems, such as a clinical decision support system, from Guidance, from Easy, from IDEA3S, Theradoc, and Treat. There are many that you can sign up for, and they have varying costs, so that's one thing to look out for. You can have an AMS pager and AMS hotline as well to port these systems to manage restricted approval, so that the doctor prescribing the antifungal or antibiotic needs to actually type in what they want to justify it, and they will get a number which then gets sent to the pharmacist and allowing the prescription of that particular drug. Here is what Guidance MS looks at. This is quite widely used in Australia. It's mandatory to obtain approvals for restricted antimicrobials. There's training for interns and JRMOs, and I think they receive, I believe, 2 to 3 days of an AMS package before they formally start work. Education has been talked about, so I will not say too much about it, but obviously an active approach outweighs the benefits of a passive approach. Be opportunistic on the AMS rounds, teach when you can, point out what the e-resources are, point out the clinical guidelines, AFWG, ANSMIC, IDSA, ECMM, and many hospitals now have phone apps that can be transmitted to the junior staff to inform them of AMS activities. Review, we've talked about this also. This is the cornerstone of AMS and is the most widely practiced strategy. The importance of starting antimicrobials without delay is very important, and yet we need to review the results of microbiology and look at the turnaround time to see indeed if microbiology results impact on the change of antimicrobials. So just sticking with reviews of prescriptions, what are some of the common interventions? Intravenous to oral switch was mentioned, very important. De-escalation compared to escalation. Sometimes AMS rounds result in escalation. Dose optimization. TDM, which I think was the subject of yesterday's talk. Microbiology interpretation and duration, advice about duration. So just a few words about intravenous to oral. In terms of fungal infections, there are guidelines, so have a look at them. Sometimes they do really help and don't tell you when to switch from intravenous to oral. but often this is because it's dependent on the fungal infection. So get an ID consult. For instance, in crypto, there are some guidelines that you use amphotericin for about 2 weeks, depending on your host group and depending on site of infection. And in candidiasis, you have to treat for 2 weeks, but when do you stop your IV echinocandin and step down to an azole? It depends on the patient. The results also depend on the antifungal agent. Azoles are only available orally, and some agents are available IV. So the switch may not be possible in the way you want it to be, depending on what agent you're using. And then we have host factors such as renal dysfunction. Can you give IV? Is the excipient safe? Are they intubated? Are they in ICU? Are they neutropenic? So it's a complex scenario. This is just a leaf out of our local hospital IV to oral switch, and we all acknowledge the benefits of conversion from IV to oral antibiotics when the patient is well and to save money. When all of the following apply, like the fever is gone, the patient is better, the patient's able to swallow tablets, a suitable oral alternative is available, the patient is likely to be adherent to oral therapy, and the patient does not have something, for instance, with candidiasis, bone and joint infection, a deep-seated abscess. CF patients are difficult to treat orally, meningitis, bacterial endocarditis. So we need to use our common sense and look at the guidelines and then determine when we can have an oral switch. Dose optimization. There are certain indications for dose optimization, and this include increasing the dose, where tissue penetration might be questionable, such as in CNS infection, meningitis, and other sanctuary site infections. Fungi with a higher MIC. So if your MIC is a little bit on the high side or above this ECV, you might tend to worry that you might want to give a higher dose so that you can get higher blood levels. And this will apply for glabratus infections and for some Aspergillus fumigatus infections. Does your patient have augmented renal clearance, as defined by eGFR of greater than 130. So if you're in ICU and they're doing all sorts of things, you've got lines in, you've got fluids going on, you need to be very, very careful. Sepsis and septic shock, hypoalbuminemia, and in patients on ECMO. Decrease the dose. A common sense one that springs to my mind is renal impairment, right? Just decrease the dose. And it depends on the drug. It depends on the patient's weight, whether they're on renal replacement therapy, and what other drugs they are on, as to whether you may need to decrease the dose. TDM, and I will not be speaking about this because we all acknowledge its importance. Oh dear. But it's an iterative process. You give a dose, you measure the concentration of a drug, you adjust the dose or continue the dose, and you measure it again. Be aware of sources of PK variability, compliance, age of patients, physiology, whether they're male or female, whether the female patient is pregnant, what are the albumin levels because of drug binding and renal impairment, drug-drug interactions, and food interactions in some circumstances. Duration. Now, this is the most frequently commonly requested advice. I didn't know this, but when I Googled this, Google came up with this answer. And many people ask, how long do we take antibiotics? How long to take this one before I convert to the next one? And there are no magic numbers. They're based on convention and they're based on best evidence medicine. 6 weeks, 12 weeks, 6 months, 1 year, and usually I don't know. So this will depend on the fungal infection. It will depend clearly on the clinical response, and it can be guided by your therapeutic guidelines or your management guidelines for invasive fungal infections. To finish off, what is the evidence supporting AMS? We all know inherently, excuse me, that there are benefits of an effective AMS program because it results in reduced antimicrobial utilization, it results in cost savings, improved appropriateness of prescribing, reduced adverse effects, and reduced hospital length of stay. Balancing measures are that no increase in infection-related mortality or morbidity has been seen if one performs AMS. I thought this was an important publication for us to reread. This was published a few years ago now, and it looked at the entirety of published evidence up to 2016. It was a systematic review and meta-analysis of clinical and economic outcomes from the implementation of hospital-based antimicrobial stewardship programs. So there are about 25,000 publications, of which only 26 studies were analyzed because the others didn't meet the criteria. And they compared the benefits, both economics and outcomes, pre and post AMS program in these publications. And it ranged from 6 months to 6 years between the pre and the post period. So to summarize very briefly, these were the high level results that were found. Certainly before the post antimicrobial stewardship, total antimicrobial utilization reduced by 20%. You might think it's a bit low, but I guess CIs weren't all that broad, so it's about 20%. It's probably about right. Antifungal utilization was reduced by 40%, reduced length of stay 15%, and importantly, reduced antimicrobial costs 35%. So all in all, it was a good thing. And when you plan your stewardship program in the hospital or in the region, all these figures can be taken as supporting evidence. What about the team? Now, this is a fictional team, and I've just dreamt this up, but let's pretend that we have AMS ward rounds 3 times a week, starting at a decent time in the morning. And the team, you've got your ID doctors, your AMS pharmacists, which are dedicated in some hospitals, and a member of the infection prevention and control team. The clinical microbiologist, in terms of antifungal stewardship, probably should be on these ward rounds as well, and also the mycology scientists, if the hospital is lucky enough to have one. And certainly I do have one and work very closely with Dr. Katrina Halliday, who's in the audience. What does the team do? Well, it goes around the hospital. It does on-the-spot education. It helps with interpreting microbiology results. It helps also with interpreting TDM results. It gives advice to the JMOs that it meets on the wards, and these JMOs are all primed to meet you when you come. They're usually waiting. De-escalation of antifungals, dose optimization, IV to orals, how long to give it for? May I stop it? Am I on the right therapy? Do I need to broaden therapy? And it's always a good scenario or opportunity to answer questions, and there are never any dumb questions that are asked. So I think to finish off, the AMS is philosophy, but it's also based on science. It's about patient safety and quality of care, first and foremost. So education is good. Enforcement is probably necessary in part. Improve your antibiotic literacy amongst your staff. Minimize the additional workload if you can, and maximize the efficiency of the system. I hope this talk has complemented the other 2 speakers and giving you an idea of which fungi we should worry about, and take that into consideration when you're next thinking about upscaling your AMS strategy. So thank you very much.